Okay. There you go. Now we're set. Thank you, Joe.
Perfect. Okay.
Joe, you look different.
I am different.
Can you see the
thankful.
slides?
No, it went somewhere. It says share. I did share multiple,
Yep. Can you see them now?
Nope.
multiple participants sharing. Share. Screen.
Let's try this again. Here we go.
There it comes. There it comes. There you go.
Perfect.
Okay.
Now it's
All right.
coming. Yeah. Okay, I'll get my glasses so I can see better. I get my glasses. No, you just have to wait a minute.
Should we wait for Leslie to come back?
Well, we can continue without her now, can't we? Or-
Okay. Okay.
Yeah,
I just
I
wasn't
think
sure
so.
if you wanted me to wait.
Yeah,
Okay.
okay.
So, well, thank you everyone for inviting me to talk with you about the Long-Term Care Ombudsman Program. We are advocates for people who live in long-term care. Now, let's see, how do I advance the slide? Let's see. Here we go. Okay, so what I'm hoping that you will take away from this today is that you'll be able to explain who long-term care ombudsman representatives are, list what we do, and describe how we fit with other aging services. And I think it's aging, actually, and disability services. So I'm thinking all of you live at home, in your own home, is that right? In an apartment, or are any of you in a facility?
Well, some of our members are, but
Okay.
I don't think, it's hard to, it doesn't look like any of those have logged
Okay.
on.
Okay, well, but you probably know people who live in long-term care, or if you
Oh,
don't
yeah.
know, you will. So, it's helpful for you to know how to reach us and to know what we do. So I want to just very briefly sort of go over the law for you. We'll talk about resident rights because that's what's really most important. And then we'll consider long-term care consumers in the aging network. I'll just talk a little bit about how you can access other aging services. So the long-term care ombudsman program, it's sort of interesting to me that it started when Richard Nixon was president, because I kind of don't think of Richard Nixon as being somebody especially interested in social services. Lyndon Johnson maybe, but it just seems sort of funny to me that Richard Nixon it took place on his watch. So the Older Americans Act authorizes long-term care ombudsman program, and we have a certain place in the Older Americans Act that's all about the ombudsman program. And then federal law related to Medicare and Medicaid also impact long-term care residents' rights and what facilities have to do for them. So Medicare and Medicaid pertain mostly to nursing homes. Medicare helps people if you have a spell of illness, you go to the hospital, you're in the hospital 3 days and you need to go for rehab in a long-term care facility. Medicare will help pay for your stay there for a limited amount of time. Medicare doesn't pay for assisted living or other kinds of residential care communities. But Medicaid might, in some states, Medicaid may help to pay both for a stay in a nursing home and in a lower level long-term care facility like an assisted living or personal care home. We call them personal care homes in Georgia. Other states call them other things. And then we have federal regulations. So the ombudsman program has federal regulations, and just this 2 minutes about what you learned in civics. The law sets out sort of in broad strokes what the law is, and then the regulations sort of fill in more details. And so the long-term care ombudsman, there's a law and there are also regulations. The same for nursing home regulations. If you look at the Medicare and the Medicaid law, it says certain things about resident rights, but then when you look at the regulations, it gives more detail about what those resident rights are and the requirements of facilities in caring for older adults. And then there is also a federal law and regulations related to enforcement. So if a long-term care facility doesn't provide the services the way they're supposed to, or if they're doing things that violate resident rights, it's a different group. It's the survey and certification group in each state and territory that looks at whether what a facility has done violates regulations, and then they have enforcement powers. They can levy fines or they can close facilities. They can even, well, they don't allow them to participate in Medicare and Medicaid any longer, and often that means a facility will have to close. And then in Georgia, we have statutes particularly related to the ombudsman program, and then a reporting of abuse of long-term care residents and resident rights, and then state law about personal care homes and assisted living communities. So if you live in, I can't say for sure about Canada, but if you live in another state outside of Georgia, that state, I'm sure, has its specific law about personal care homes and assisted living, because there's no federal law related to that. And there may be other things that specify how the ombudsman does the work that the ombudsman does. So in Georgia, my office, we report to the Commissioner for the Department of Human Services, and actually currently we don't report to the commissioner, we report to a designee, because the commissioner is married to the guy who lobbies for the Nursing Home Association. So kind of a huge conflict of interest. But we are part of, but we're not directed by, the State Unit on Aging in the Older Americans Act. It sets out the ombudsman program separately from area agencies on aging, and also a state unit on aging. So we work with the State Unit on Aging, but we are not directed by them. And then the Older Americans Act also requires that the ombudsman program be involved in public policy, advocacy, and interacting with the media, which in our state, in Georgia, any other state employee is prohibited from public policy advocacy, almost all of them. And in our department, the Department of Human Services, every year regularly, periodically, we get this notice that, if anybody from the news calls, you don't talk to them, you have to send them to communications, except for us. We can talk to the media. And in fact, a couple of years ago, the woman who is now the commissioner for the Department of Human Services worked for the governor. And I was just letting them know that I'd had an inquiry from the media and I'd responded to it. And she sent me an email and she said, well, in the future, don't respond to them, just send them to me. And I said, oh, no, sorry, can't do that. Federal law says I have to talk to the media. She wasn't very happy about that, but she understood. So in Georgia, the way our Office of the State Long-Term Care Ombudsman operates, we contract with 6 nonprofit agencies who provide ombudsman representative services. So it's an annual contract. The local entities hire the ombudsman representatives. They have paid staff. So we have about 40 paid ombudsman representatives in the state of Georgia, and we have some volunteers. The ombudsman representatives are trained and certified by the state office. So although the ombudsman representatives get a paycheck from the agency that hires them, whether they can continue to operate as ombudsman representatives is determined by the state office. And all the counties in the state are covered. So in Georgia, we have 371 nursing homes and 2,000 plus assisted living and personal care homes. Our ombudsman representatives visit all of them quarterly. That's not true in every state. We're very fortunate in Georgia that the General Assembly and the governor, essentially, mainly the General Assembly, though, provides funding for us so that we can be sure that we're advocating on behalf of all long-term care residents, not just nursing home residents. Not all states are able to visit what they call residential communities. So the personal care home or assisted living communities, some states don't do that. They just don't have enough personnel. They don't have enough money to do that. But we're fortunate, very, very fortunate in Georgia that we have good support. And so we visit, our ombudsman representatives visit residents quarterly. And this is just how our state is divided up. So each area provides services to about 12,500 long-term care residents. So you can see this is Metro Atlanta, part of Metro Atlanta. So Cobb, Fulton, and Douglas has 12,500 long-term care residents, as opposed to this huge swath of South Georgia that also has 12,500 residents. So they're just a lot more spread out. All 50 states, the District of Columbia, and 3 U.S. territories have an Office of the State Long-Term Care Ombudsman. Now, did I count that right? It's Puerto Rico, Guam, and the Virgin Islands. I think that's right. And then the District of Columbia. All long-term care ombudsmen have the authority to serve residents of nursing homes and what the federal law describes as residential care communities. And like I said, each state describes residential care communities a little bit differently. In Georgia, we call them personal care homes and assisted living. I think most states have something at least called assisted living. Not all of the offices of the state long-term care ombudsman have the funding to serve all long-term care residents. So again, we're just really fortunate in Georgia that we're able to do that. So, gosh, do you want me to pause for questions, or do you just want to ask questions at the end? How should we do that? Well, so let's do this. If you have a question, just pipe in if you want to. I was talking a little bit about how we're organized. Now I just want to talk a little bit about what we do. So you might have some questions in this part too. So ombudsman representatives protect the rights of individuals living in long-term care facilities. We don't protect the rights of their families. We don't protect the rights of the employees that serve them. We protect the rights of those who live there. And we do that by regularly visiting long-term care facility residents. And so in some assisted livings in Georgia, I imagine this is probably true across the country. Some are fairly high end. The people who live there are fairly sophisticated, and their family members are fairly sophisticated because they're usually pretty expensive. And so often the people who live there are able to resolve whatever their problems are, because they're used to doing it. They're used to, just sort of telling people, I want you to do this or that, and they sort of work it out. So there are some, particularly assisted livings, that really probably only get visited once a quarter. Lots of other facilities really get visited more than that because people have complaints, concerns, or our ombudsman representative might have concerns about what they're observing. And so they may go more frequently than quarterly. We are there to talk to residents and find out how their experience is, and we're there to observe the facility, but we're also there to respond to complaints. And complaints can be anything. It can be, they've lost my laundry, or it can be, they're not bringing my medicine, or I haven't gotten my medicine in days and days, or my caregiver hurts me. I mean, that happens sometimes. And so we resolve the problems to the best of our ability. And, we've all, I think all of who I see on this call, we've all lived long enough to know that sometimes you just can't make things right. Sometimes it just isn't going to be right, but we do the best we can to resolve the problem to the residents' satisfaction. And we'll talk a little bit more about that. We also provide information like what I'm doing today. Our ombudsman representatives are required to do some community education. They also do training at facilities. And so we provide information. We also work with organizations like AARP, or that survey and certification agency that I mentioned, the one that does the enforcement. Our aging network partners, such as area agencies on aging, and every state has area agencies on aging. Adult protective services, Aging and Disability Resource Connections, the Medicare Insurance Counseling folks, and others, you know, anyone else who's involved in aging, you know, we may be working with them, collaborating with them. We might be a resource for them. And then we promote systems advocacy. And when we say systems advocacy, what we're talking about is advocacy that affects more than an individual. And we'll talk a little bit more about that too. So this slide, we'll do a little gymnastics at the end. So, but let me just explain what this is. So ombudsman representatives are resident advocates. So you see in the middle, we're talking about residents because we're resident focused. So you don't know if you've heard about person-centered care. People sometimes talk about person-centered care. We've always been person-centered because everything we do is related to the resident. So at the very top, we seek to resolve complaints to the resident satisfaction. We represent resident interests. So whether that's with public policy makers or maybe even with the media, we do that. We empower residents and we promote their self-advocacy. It's like I was mentioning, some facilities, the residents are very sophisticated. They know what to do and they, you know, advocate for themselves all the time. And some facilities, residents may have more cognitive issues. They might not have ever felt empowered. And so sometimes we have to kind of, you know, help them feel empowered. And sometimes we, you know, take action with their permission. We have to have resident consent before we share information. And we actually have to have resident consent before we take any action either. So the resident guides the action. Now here's the gymnastics. I didn't make this slide, so I don't know how to turn this off. So we do a little gymnastics and then we get here. So the federal law, the Older Americans Act that I mentioned, is very clear that the confidentiality requirements we have mean that we can't share resident information without the resident's consent. So if someone were to call and say, well, I have a friend. So if one of you called and said, oh, I have a friend in a nursing home and she's not getting a shower. She's not getting a shower like she wants to. So you go help her. Well, we have to go and talk to the resident. Now the resident might say, well, that's true. And yes, you can help me. Or yes, that's true, but no, I don't want you doing anything about it. Or no, it's not true. I'm getting a shower. I'm happy with my showers. So we have to take our cue from the resident. So even though, you know, it's a friend or a family member who's called to say there's a problem, the resident has to confirm that for us. And then we take action depending on what the resident tells us. Federal confidentiality requirements also prohibit the sharing of complainant information without the complainant's consent. So let's say Rita called me and said, my friend Sherry is in a nursing home and she's not getting a shower. So we would say, Rita, is it okay with you if we tell Sherry that you're the one who told us? And Rita might say, oh, sure, go ahead. I've already talked with her about it. Or Rita might say, oh, no, you know what? No, don't tell her, but I'm just letting you know, would you go check on her? And if Rita says no, then we can't share that. Now, this is important because almost everybody who works in a long-term care facility in Georgia is a mandated reporter. And I venture to guess that that's probably true in most other states, although it's state specific. Well, I say that. In nursing homes, there is a requirement that if someone who works at the facility has a reasonable suspicion of a crime, so this would be exploitation, abuse, neglect even, then those employees are required to report. But in Georgia, I can say that very clearly that just about everybody in the nursing home is a state mandated reporter. That means they have to report to law enforcement and the agency that regulates the facilities if they have a reasonable suspicion of a crime, but not ombudsman. kind of like, clergy don't have to report. Oh, and gosh, Barbara, I see your hand up.
Just a question. I understand the role of confidentiality. What happens if the resident has dementia, where the family member says not receiving a shower twice a week or whatever the standard is, and not getting any response from the people in charge?
This staff. That's a good question. So for us, our ombudsman representatives have to go and talk to the resident, and we have to assess whether the resident understands what the complaint is and what the situation is. So you probably have known people who have dementia, like my dad and my mom too. My dad had dementia. So he would say to his wife, what time am I going to the doctor again? Am I going to the doctor today? It's my appointment today. What time am I going? But if you asked him, hey, Dad, have you been to the grocery store? Yep, I went to the grocery store yesterday. And bananas are like, because he ate bananas every morning, bananas like 10 cents more a week this week than they were last week. And he was right. He was right. So, dementia is kind of a continuum. We are not clinicians, so we don't do a mini mental exam. We don't do any of that. But our ombudsman representative would go and talk to the resident to see if the resident really sort of understood, yeah, I get a shower. Okay, do you get a shower every week? And we would ask some questions, try not to be leading, but just try to get a sense of whether the resident really could sort of tell us, no, I'm not getting a shower and I'd like to have one, or everything's fine, I don't want you to do anything about it. And so sometimes, our ombudsman representatives can tell that the person doesn't really understand and isn't really able to say. And at that point, then we would think, well, what do we do to protect the health, safety, welfare, and rights of this resident? Well, if the resident isn't getting a shower, that's, their personal hygiene is going to have a problem. And so then we would take some action, and we would talk with the person who is the complainant about it. But if the person could tell us, yes, I'm supposed to get a shower on Tuesdays and Thursdays, and last Thursday I decided I didn't want to shower, or for the last week I didn't want to shower because I didn't feel like it. And if the ombudsman representative thought they really sort of understood, if the resident said, I don't want you doing anything about it, we wouldn't. And we would ask the resident, is it okay with you if we report back to the person who complained? And if the resident says yes, we would. And if the resident says no, our ombudsman representative would be back in touch with the person who complained and say, I've been out to talk to the resident. I'm not at liberty to tell you what we discussed. So Diane, you have your hand up.
Yeah. When my mother was in a nursing facility here in Florida, she did have dementia, and I was her medical surrogate.
Mm-hmm.
So, but we did not have her declared medically incompetent.
Mm-hmm.
So she had a right to say what she wanted medically, and doctors and nurses and caregivers would explain things to her. As the representative for the resident that you are, say a person is declared medically incompetent
Mm-hmm.
by the family, and there is a medical surrogate that you have to discuss. So you would then have to, instead of asking the resident that it's already declared,
Mm-mm.
do you ask the medical surrogate?
Mm-mm. No, we don't. We don't. Well, but here's how it works. So I'm speaking about Georgia because I don't know exactly how it is in Florida, but in Georgia, when the court says that you can't make responsible decisions about yourself or your property, they're specifically, the rights they take away are to make medical decisions, like whether you're going to have surgery or not.
Right.
Or whether you can make a contract, whether you can buy a house, whether you can get married. But, a lot of times the issues that come to us are not those, and we are not clinicians, so we don't get involved in medical issues, except if a resident said, I'm not getting my medication on time. We don't look at whether the medication is the right medication or whether the person delivering it is the right person. We would then, if we had permission of the resident, we would go and ask the director of nursing, for example, is this resident getting her meds on time? Because it doesn't look like it. Can you show me the MAR so we can see whether that's actually what's happening or not? So, but if the resident wanted something that it would require the guardian to decide, we would talk to the guardian about it, but we don't ask the guardian permission first
Okay,
to go talk to a resident, because a lot of the things that residents, the concerns they have aren't really covered by guardianship. You know, like I did a presentation, gosh, a long time ago about, you know, younger residents who have some developmental disabilities. And, you know, they want to wear shorts and it's wintertime, but they're not going outside. So who cares? It's okay to wear shorts. You know, it doesn't need to be a big fight. Yes, they can wear shorts. They can wear plaids and stripes. They can decide they want to eat their chicken and their ice cream and they don't want to eat their vegetables. You know, it's okay. So, you know, it depends on the situation, but most of the time, especially when it comes to a medical agent, we wouldn't be involved with a medical agent because we're not clinicians. We don't do that.
okay.
Unless the resident was just very adamant about some sort of a medical thing that was going to happen and they didn't want it for whatever reason. And then we do our best to try and resolve the issue. And so sometimes that means compromise.
Yeah.
So,
Thank you.
yeah. Our complaint investigations are not like a law enforcement investigation. We don't have to prove anything happened. We have to just assess, is something bothering this resident? And if so, what can we do to maybe make that better? So, and you know, if you think about it, people who live in long-term care are living in a congregate setting. Have you ever lived? Did you grow up in a family that had more than one? Do you have siblings, or did you ever live in a dorm, or were you ever in service? And so, you know, when you have people living together, you're going to have issues. You just are, you know, it's just human nature. And so for us, we don't have to prove that, yes, your roommate's television is too loud, or we don't have to prove that the facility staff intentionally put your clothing in the wrong closet. We just, you know, the resident tells us a situation, and if it seems to us probably like that's the issue, then we would verify it and we would talk to the resident about how we can help them resolve the issue. And what happens some of the time, where we have, you know, plan A, plan B, plan C, you know, so plan A might be something that seems most reasonable to somebody who doesn't live in the facility. We don't live there. So the resident might say, no, I don't want to do plan A. So then we come up with plan B, an alternative. Would this work? No, how about plan C? Well, okay, we can try that. So we'll talk about some specifics in just a minute, but our purpose is to just try to figure out what can we do to help this resident feel satisfied that the issue that they have raised has been addressed. And sometimes what we do is individual complaint work, and sometimes it affects more than one. So systems advocacy really focuses on influencing and changing the system. So it could be the system at the facility. So it could be that we're talking to the facility about making a change that would affect everybody. Or it might be the local community. So maybe something's going on in the city or the county that's affecting what residents can do or not do. Or it might be the state or the federal level. And systems advocacy includes policy and law reform. So that could be that we're advocating with like the health department in our state, or the agency that oversees Medicaid, because lots of people who live in long-term care, Medicaid helps to pay for their care. Or it might be that we are going to our legislators. So in Georgia, it's the General Assembly. So we might be going to the General Assembly and asking them to change a law. Or we might even be sending letters to folks in Congress, talking to our Congress folks. Or we might be working with the media, or there might be community trainings or other things that we do to help to change the system for long-term care residents. So here's an example, a facility advocacy. So on behalf of all residents, we might walk into a facility and they have bugs. You don't know if any of you have been in a long-term care facility and you've experienced that, but I used to visit residents in a nursing home near downtown Atlanta. It's near the Martin Luther King Center. It's a really, really old building, and they always had gnats. Just always had gnats. Well, I could observe them when I walked in. When I talked with residents in their rooms, they'd be waving away the gnats, and so would I. In some facilities, it's not so much gnats. It might be other bugs, or roaches or whatever. So things that we might observe, the ombudsman might observe, we might talk to the facility on behalf of all residents. You got bugs in the building. What are you doing? What's your pest control plan? How often do they come out? Are you aware that this is bothersome to residents and to visitors, to everybody? And so what are you doing about it? So that could be facility level advocacy for a systems advocacy situation. Often residents have complaints about food. Not as much in the nursing home as in assisted living and personal care homes, but in nursing homes too. And so it may just be one particular resident who is getting the wrong meal. And this came up actually fairly recently. One of the ombudsman representatives was telling me that the resident was getting the wrong meal. She was supposed to have maybe mechanical soft, and they were just giving her regular food. I forget exactly the details, but so the ombudsman representative asked the resident, may I talk to dietary folks about making sure that you get the right meal? Now, if the resident said no, then she couldn't. But usually, especially when it comes to food, residents usually will okay that. In fact, I'll just tell you a quick story. I was visiting at that facility that I used to visit, and there was a woman who, it was like, I don't know, 2:30 in the afternoon, and it was a double room. Most rooms in nursing homes in Georgia anyway have at least 2 people and sometimes more. And so she sort of did like this, and she picked up this piece of chicken that looked like maybe it had barbecue sauce on it. And she said, look at this, I can't eat this. This is awful. And so I said to her, well, did you ask for an alternate meal? And she said, what do you mean an alternate meal? I said, well, you can always ask for an alternate. She said, I can. So I said to her, well, do I have your permission? Is it okay for me to go out and talk to the staff that are out in the hallway and see what the alternate meal is? And then you can decide if you want it or not. So I go out there and I ask the certified nursing assistant. She said, let me check. And she comes back and she says, oh yeah, the alternate is liver and onions. You know, that was not true. That was not true. Whoever offers liver and onions as an alternate. So I said to her, well, let me check with the resident, but I'm guessing she might not want that. So I asked the resident. Of course, she said, no, I don't want liver and onions. So I went back to the CNA and I said, don't you have sandwiches also available as alternates? Like, maybe a ham sandwich or a peanut butter sandwich. And so she checked and she said, sure, we have a ham sandwich. We can bring our ham sandwich. And so I went back and asked the resident. She said, oh, that would just be so wonderful. She just didn't know, so this is individual advocacy. So the CNA made arrangements, and sure enough, she gets a ham sandwich instead of this chicken that she just didn't really like. So sometimes it's an individual case, and sometimes they're very serious. It may be that a resident will say, my caregiver is hurting me, or they're not providing my medication, or they're making me take medication that makes me really, really sleepy, and I don't think I should have to take it, so it depends. It kind of runs the gamut. And then we have done a lot of advocacy during the pandemics over the last 3 years related to visits. So it might be for all residents. So sometimes facilities have just kind of gone on lockdown when they're not supposed to, especially, I think it was November of 2021. CMS came out with a directive that all residents have the right to visit with any visitor that they wish at any time. Now, they'd been on lockdown because CMS had not done that. They allowed facilities to really lock people out, essentially. You probably, if you had friends in long-term care facilities, you probably experienced that. You could talk to people over the phone. You could wave at them through the window. They'd let you on the property to sort of wave through the window, but you couldn't go in. And since that time, we have had individual residents who've had trouble, even now, with their loved one coming to visit the facility, trying to put up roadblocks. And sometimes it's even more broadly than that. In fact, so there's a facility that an ombudsman representative called me just last week to say that they have COVID in the building. And so they've told all the residents they can't go out at all. So they have an interior courtyard that's outside. I mean, the building is in like a square and the courtyard is in the middle. They wouldn't even let people out in the courtyard. So our ombudsman representative had to really do some advocacy to allow residents to get outside to see the sun and just be outside. So at the federal level, we've been advocating for a federal staffing ratio in nursing homes. So right now you have to have enough, but you can't, there's no, like if you have 100 people in the building, there's no math. Like if you have 100 people, then you have to have 1 registered nurse and 2 LPNs and 20 CNAs. There's nothing like that. They have to provide a certain number of hours per resident, and they have to have enough. So it's really hard for residents to know if there are enough people. And often they wait. This is one of the biggest complaints we get, is that they wait a very long time for someone to come and assist them. Family members don't know. We don't know. Ombudsman representatives don't know if they really have enough staff or not. We've been advocating for the state staffing ratio in residential care communities. This is personal care homes and assisted living communities to stay as it is, because they do have a ratio. So if you have 20, I'm making this up because I don't remember exactly how the law is, but if you have 20 residents, you have to have at least 1 staff person. Or 2, I forget. But anyway, they wanted to reduce that. And so we've been advocating to leave it as it is, not to reduce that. And then we might advocate at the county or city level. In this particular instance, residents of a nursing home wanted to go across the street to the convenience store. It was kind of a busy street, and the facility didn't want to let the residents do that. And you probably know this, but I think often people just in general who don't really have much experience with long-term care think that once you're in there, you're kind of locked in. You're kind of in jail, but you're not. And so even people who live in nursing homes, who are more disabled usually than people in personal care and assisted living, they still have the right to get outside. If they want to take, get in their wheelchair and go across the street to the convenience store, they have the right to do that. But the issue there was the street was kind of a busy street. And so our ombudsman representative was trying to figure out how to advocate with the city or the county to do something so that whether it's a stoplight or a caution for people trying to cross the street, that it would make it a little safer. For the ombudsman program, anyone can complain. So whether you're a loved one, a family member, a friend, you're just somebody who happened to be in the building and you saw something that you thought didn't look right, you can complain to the ombudsman program and we'll investigate. But we won't resolve the issue to the complainant's satisfaction. We'll resolve it to the resident's satisfaction. So it could be that we've gotten these calls from hospice staff, for example, who say, you know what, things just don't look right in this building. Or it could be area agency on aging staff who are in the building to help a resident who might want to move out. And maybe they say, we're seeing things that didn't look right. And then we would go and investigate. So we advocate for residents, not the complainant. Sometimes we'll get a call from a family member who will say, facility won't let me visit my mom, and I want you to help me. And so we'll say, well, we got to talk to your mom because it's the resident's right to visit. It's not your right to visit. Families don't like to hear that from us, but that is what it is. And we say it tactfully. I don't want you to think we just sort of say, no, we're not going to help you. But we're all about the residents. Sometimes we'll get a call from a family member who will say, my brother is the black sheep of the family. And whenever he goes to visit my mom, she gets all upset. And I want you to make sure that he can't visit. Well, that's not how it works either. We would go and talk to the resident. If the resident didn't want to see the black sheep of the family, then we would remind the facility that it's the resident's right to say no. But if she wants to see him, she has the right to see him. We always have to have resident permission, and as the state ombudsman, it's my job to make sure that our ombudsman representatives are doing that. So we've had a few that were decertified, meaning they can't do the job anymore because they didn't ask permission. They took action without getting the resident's consent. And we have zero tolerance for that. The complaints have to be related to the resident's experience in long-term care facilities. So if a family member called and said, my mom is having trouble with her financial advisor, we would say, well, you might want to get some legal advice about that, but we can't help you with that. That's not the scope of our services. Have to do with the resident's experience in the facility. So if the facility is not allowing the resident to have their personal needs allowance, we would get involved in that. So it has to be, the issue has to be related to their experience in the facility, and it has to be while they are a resident. So sometimes families will call us after the resident has died or after the resident has moved back home and asked us to take action on behalf of that resident, and we can't because our authority is only for residents while they're resident. And then again, we resolve complaints to the resident's satisfaction. So we make referrals to the aging network if the resident will give us permission. So when I say the aging network, this would be, for example, if a resident had a concern with their Medicare, maybe they're new in the facility and they'll say, I came here from the hospital and I don't think the Medicare is working. I don't think they're paying for me, or I don't think they're doing what they're supposed to do. We would refer them to the insurance counseling, the state insurance counseling folks. And every state has an insurance counseling program related to Medicare for older adults. We don't know the Medicare rules. Again, that's not the resident's experience in the facility. That's the resident's insurance issue. Well, we'd refer them to, in Georgia, we call it, well, actually, they don't call it Georgia Cares anymore. They just changed their name, but it's the insurance counseling folks. Or often residents tell us they'd like to move to a different long-term care facility. Like, I'd like to move closer to my family. And we would refer them then to the Aging and Disability Resource. We call it the Aging and Disability Resource Connection in Georgia. I just looked this up in Florida. It's the Aging and Disability Resource. The C stands for something else in Florida. So, but it's the service that helps people figure out all different kinds of aging services. So whether you need home and community-based services, or maybe you need an attorney, you're trying to find an attorney to help you with an aging issue or whatever, the Aging Disability Resource Connection helps with that. If the resident is being exploited by family members, and this happens a lot, the resident's check is going to the family who is living in the resident's home, and they're paying the resident's mortgage, or they're paying other bills with the resident's money, and they're not paying the nursing home. And, it's no free lunch. If you're in long-term care, you got to pay for it. We would refer that to Adult Protective Services for them to find out what the family's doing and see if they can resolve that problem. Very often residents tell us they want to go back home. And if they've been in the facility for a while, they probably don't have a home anymore. Their apartment was rented to somebody else, or they had to give up their house. And so they don't have a place to go. And there's a program called Money Follows the Person. And we would refer them to the Money Follows the Person counselors who would help them. And that program helps a person who's lived in a nursing home move back to an apartment, and helps with deposits for utilities and buys them furniture and does the rent deposit and make sure they have food. It's a really good program. It's not everybody can qualify, and it's not like an unlimited amount of money that's available, but we refer a lot of residents who say they want to move home. We refer a lot of them to the Money Follows the Person program. And our number one complaint in nursing homes is involuntary discharge. So this happens a lot, especially family has control of the money, they don't pay. The facility gives a discharge notice to say you're not paying, so you can't stay. So we then refer that to the Elderly Legal Assistance Program for them to help appeal the discharge. And sometimes there are reasons, they can appeal a discharge. Sometimes, well, they appeal, but they might not win the appeal. And the Aging Network mission is to serve older adults in our communities. So some of the time we just have to kind of remind people that even those who live in nursing homes and assisted living, they're still part of our community. That nursing home is in Atlanta, in Marietta, where I live, or, wherever. I mean, they're still part of our community. And so we remind our partners in the Aging Network that residents look forward to interacting with their family members. A lot of people don't have any family. So, but maybe their friends, or maybe someone who had been the pastor of their church or their synagogue, their rabbi at their synagogue. Or, sometimes school children will come to facilities and they'll, do a Christmas program, or they'll sing songs, or, whatever. Even vendors. I mean, think about, if you're living in a place that is not your, what used to be your home, your comfortable home, you're living now in a congregate setting. You see the same people every day. You'd like to see somebody new, a visitor or a friend or a family member, whatever. So residents do look forward to interacting with other individuals. And so I have a friend I used to work with, he and his church, they just make a regular visit to the nursing home in his little community. They just, I don't remember if it's monthly or quarterly, but they just go and visit, just, because they know people need to visit with other folks. And so for Georgia, we have a website. You can go to our website and get some information. I will make a confession. We are not, none of us in my office are big Facebook, Instagram, TikTok, whatever people. So the stuff on our website is not like something new every day, a new picture, a new story, a new whatever. But the basic information is there. And what's most helpful, I think, for most people is you can click on the county where you are, and you can find out who the ombudsman representative is who serves the residents in that county, for example. But there's an explanation, more explanation about what we do and how to reach us. And that's pretty much the presentation, I guess. So Dick, I see your hand up.
Yes, thank you for a wonderful, very detailed program. My older 89-year-old brother just went into a long-term care facility in Charlottesville, Virginia, and he's looking at 4 to 6 weeks or whatever. And which begs my problem, and that is I'm really impressed with a large number of agencies you have in Georgia and your ability to work with all of them as a informational resource. Is that typically the case in like the state of Florida or state of Virginia?
Yes. So in Florida is the Department of Elder Affairs. So you would check in with them. You have area agencies on aging. The ombudsman program is a little different in Florida. My understanding is they use volunteers more. And so I don't know exactly how they address issues in Florida. But in Virginia, there is a state ombudsman in Virginia, and they have area agencies on aging as well. So the state ombudsman in Virginia is Joni Latimer, and she's been the state ombudsman for, I don't know, probably 20 years. But they would be very helpful to your brother, even if he thinks he's only going to be there for rehab for 4 weeks or 6 weeks. He still might not like the food, or he still might think they're losing his clothes, because that happens. Even when you put your name in your clothes, it's fairly easy to fold your clothes up and put it in your roommate's dresser drawer or hang it up in the closet of the person in the room next door. So yes, if he needs anything, are you pretty savvy with the computer?
Yes, I am. But I guess what I'm concerned about is that most states have as many different sub groups
Yes.
like you just talked about that
Yes.
take care of all these individual smaller problems?
Right, yes. So every state has an insurance counseling program. So if he had an issue with his Medicare, for example. So if you Googled long-term care ombudsman for Virginia, or if you Googled area agencies on aging Virginia,
Mhm.
it's many of these services are available through the area agency on aging.
Mhm.
But so I'll just give a shout out for my colleague Joni Latimer. You could call her and say, my brother's in this facility and his worries are something about his insurance and something about exploitation. Not that it is, but and she would be able to help connect you. Most of my counterparts are pretty well versed in what their state resources are, and she'd be happy to help kind of direct you or your brother if he, sometimes people in long-term care have their own computers and they're able to do stuff, but if he doesn't have all of that, you could do that for him. But yes, the states have very similar resources. Every state's got adult protective services. Every state's got insurance counseling. Every state has got an elderly legal assistance program. Some are more robust than others, but yeah,
Good, thank you.
sure. Barbara, I see your hand.
So you kind of addressed it a little bit, but if arrested, say, doesn't have access to a computer, how would they contact you?
Oh, gosh, the most important thing, and I didn't say it. When our ombudsman representatives visit, they don't usually visit with every single person in a facility unless it's a really small one, because they can't do it any amount of time they have. But what they do is they bring a brochure with their phone number on it. And so to the residents that they visit, they will give a brochure, and we recommend that the ombudsman representatives try and see different residents each time they visit, so that they're, they might not get a brochure to every resident, but to many of them. The facilities are also required to have a poster up. And in Georgia, it specifically says that it has to be the poster provided by the ombudsman, and it has to be displayed in a
prominent
place.
Mhm.
Yes.
Okay.
So a lot of times the posters are near the nurse's station, but it's interesting. Our posters are pretty big, especially the nursing home posters. They're pretty big, and they're red and white and gray, and they don't have a lot of writing on them. They say, ombudsman, if you need help, here's the number, something like that. But my husband was really sick. He was in the hospital a few times in 2021. And what I realized as the loved one of someone receiving care, I wasn't looking at whatever's going on in the hospital. I was on a mission to get to his room, so I wasn't looking at the walls. I wasn't looking for posters and stuff. So it occurs to me that some of the time visitors are probably not looking for our poster. But when we do community events, we mention, that there should be a poster up. And some of our programs, I can't say whether other states do this, but I know for us, for example, sometimes our posters might be at the probate court. The probate court might allow us to put a poster up so that people who are in the courthouse are seeing this information. So we try to put in the library, like we might have our poster up in the public library so that people know that they can reach us. But the facilities have to have the poster up, and we try to remind residents when we see them, or family members if they call us, here's where you can find the number. So if you know somebody else who needs to know how to reach us, here's what they can do.
Okay, thank you.
Sure. Rita, you have a question?
Yeah, I had a question. I would like to know when this program started in Georgia, and was it the result of the Georgia legislature, or did it come from the governor's office?
No, actually, so I think I'm saying this right. The pilot program during Nixon's administration started in 1972. We were not one of those states, but in 1979, the Older Americans Act put forward this requirement that all of the states must have a office of the state long-term care ombudsman, and in the Older Americans Act, they describe it as a state unit on aging. So the state unit on aging had to be sure that there was an office of the state long-term care ombudsman. So yes, the governor and the General Assembly, or the legislature for each state, has to be on board with it, because you have to have some funding. Well, in a few states, there is no state funding. It's only federal money. And so all they do is visit nursing homes. But in our state, anyway, started in 1979. And so we've been, and we're fortunate, not all states are able to have as many paid staff as we are. So we're very fortunate that we can do that. But it just means that the visits are probably more consistent, because when you have a program with volunteers, that lots and lots of dedicated volunteers, but if you're relying on a paycheck to keep your family going, you're probably going to be really, really serious about trying to get your work done, as opposed to, and I should maybe just speak for myself, but when I'm a volunteer, if I've got something else that's come up, I might say, well, darn, I'd really like to do that volunteer work today, but you know what? I've got to take care of something else. Where if it's my job, I'm at my job 5 days a week. Actually, it's 4 days a week, but, because if I don't do my job, I'm not going to get a paycheck. So we're really fortunate, I think, in that. Other
Melody?
questions? Yes.
So I used to volunteer up in North Carolina. I was one of the volunteers, and I did it through our county. Now, I would not have known about the whole program, except the county had volunteers and there was a council for aging or something. So I thought, okay, I'll volunteer on that committee. And then it turns out we were the ones that visited the nursing homes. In that county, Durham, we were able to go unannounced. So it was in my own time. So I was a volunteer, but I could go, I had a few team members. We would kind of go together, go to different rooms once we visited, but it was very flexible on our time. And then I moved to a different county, and the ombudsman person there, she had everybody go on a certain visit that was never unannounced. So the nursing home knew when we were coming, which was not a good thing. And so I wasn't able to continue to volunteer, but if I put a plug in for being a volunteer under the ombudsman program, because it's one of the finest things. I just love doing it and love talking to the residents. I had one situation though, I'm going to tell you about, because you mentioned it about some of the wealthier homes where people go, being different than the others. I've always told my kids after this experience, put me in a Medicaid facility because in the Medicaid facility, I think there was just a difference of income category between the people that work there and the residents. So that sort of helped when they were more equal, I think. But in the Medicaid one, they had roommates when they put them out like in wheelchairs during the day and they'd bring them out to a community room. They put people so they could communicate and talk to each other. And then we went to this very wealthy area home. And it was frightening. First of all, the residents were afraid to talk to us. They were in individual rooms. And when they took them out in wheelchairs into the community room, they kind of put them in opposite corners and set them down so they couldn't even communicate. And all three of us had the same impression. It was almost spooky. It was like wealthy, but the people were like afraid to talk to us. So we reported it because then our next job was to go to the facility manager and tell her what we had witnessed. And she was saying, she just blamed it on staff. Oh, we just have a hard time getting good staff here. And I thought, well, yeah, it's a scary place to work. The residents are all scared. So we never knew, we reported it to the main state ombudsman person, and she was great, or our regional person. And I hope she was able to do some more investigation, but never assume just because it's a nice place and people have their individual spaces. To me, that could be less safe than one.
Right. Right. Yeah. Thank you. Thank you for that, Nancy, and for talking about volunteers. We're always looking for volunteers. In Georgia, we have 3 levels of volunteers. So we have some folks who just want to visit with residents. They don't want to do any kind of problem solving. And I totally get that. You know, I mean, I think that people who are most successful as ombudsman representatives are those who really just enjoy talking to people and hearing the stories. Yeah, you know, hearing about their life experience, and a lot of the volunteers, that's all they want to do. And then if the resident says, but I have this issue, they say, okay, you tell me, and I'm going to give it to someone else, and they'll get in touch with you. I mean, you know, with permission, of course, they have to say, is it okay for me to share that? Then we have a level of volunteers that are able to resolve fairly simple things, like my coffee's always cold, or my laundry's missing, you know, things that are fairly easy to address. And then we have a 3rd level, and that level of volunteer goes through almost the exact same training as our paid staff. And those volunteers, the senior certified volunteers, are authorized to try and resolve any kind of problem, whether it's a simple problem or a much more serious problem. So we lost a lot of volunteers during the pandemic. In fact, so I think sometimes people were afraid that they might be asked to go into facilities while everyone was sick. We didn't do that. But I also think some of the volunteers thought, well, gosh, you know, I've been volunteering and the pandemic's been going on for a couple of years now, and I might as well go volunteer for something else because I can't go in, because we didn't have our volunteers go in until, I don't know, a few months ago. Well, maybe last summer. But, you know, we tried to be really, really careful, because we didn't want anyone to feel pressure that they might be exposed and then they would get sick. And so I think for some of those volunteers, they just sort of thought, well, you know, I don't have anything to do, so I'm going to go do something else. So we're working on trying to recruit more volunteers. Every state does it differently. And so I know in North Carolina, they do it through the county. For us, it's through the individual program. So each program does their own recruiting, and they might recruit students. They might recruit, you know, older adults. It just kind of depends, you know, on who's got time and the interest. And, you know, it's important that people really understand the confidentiality, that they understand conflicts of interest. So, you know, if they were visiting at a facility and all of a sudden their family members are there, they probably shouldn't be the one who's visiting as a visitor for the program. They just want to visit, you know, because their family members are there. So there are a few key things we want to be sure of, but it's helpful to hear your experience, Nancy. I think that's really, really helpful. In fact, you mentioned when we were talking on the phone about having a roommate, how you said that was really helpful because you got kind of 2 people sort of seeing what's happening. Not everybody looks at it that way, but I think that's a pretty good way to think about it, especially, you know, there are a few people in long-term care facilities, nursing homes or personal care homes that are, you know, maybe they're there because they just have trouble, like maybe their arthritis is such they can't cook anymore. They can't make their bed. They can't do some of those things anymore, but they're pretty with it otherwise. And there are lots of people in long-term care who have, you know, cognitive decline or other vulnerabilities. So I think you're right, Nancy, when you mentioned, you know, sometimes it's good to have, you know, people with a little bit different abilities kind of together so they can sort of watch out for each other. And yeah, I think that's a good observation.
One of the things, just to add to that, was one of the staff person was telling us how this was like her family, and she'd been working there, you know, as a nurse's aide. I mean, it's not a high paying position. 30 years.
Yeah.
You know?
Yeah.
And I'd much rather be in a place like that where they love their job, you know, so.
Right.
Than
And
having all these young girls that this was probably their first job.
right.
And,
Right.
so.
Well, yeah. And, you know, we have a lot of facilities in Georgia, and we have some that, yes, the administrator's been there for ever and ever, and the director of nursing and some of the other staff. And those are wonderful, wonderful places. And then we have others that, the people who are supposed to be doing the work are on their phones, and they're, they almost can't be bothered with doing the work. And so, it's a mixed bag. And like most industries, there's a shortage of people to do the work. And so even those, I think we've experienced this, our ombudsman representatives have experienced this, where they are in a facility, they know the certified nursing assistants, the direct care workers are trying to do the best they can to provide care for people, and they're stretched really thin because they just don't have enough. And so then the care is not what the care should be, not because they're not trying, not because they don't want to do it, because they don't have enough staff. And so they're trying to do it as quickly as they can. And so, what we hear often is that people are not assisted to the bathroom, and that they're not being cleaned up like they should be. And so it's not only a health issue, because that breaks down your skin, it's a dignity issue too. And a lot of people just, get frustrated because, their dignity is not being respected. Hi, Pat. You have your hand up.
Hi. I was wondering, have you ever experienced family members trying to take advantage of a patient? And if so, how?
Oh, yeah, all the time. So usually it's a financial exploitation thing. So it may be that family members, so let's say it's the mom lived in her own home and took a spill, broke her hip, went to the hospital. Now she's at the nursing home. She's taking a really long time to rehabilitate. They're not sure if she's ever going to be able to go home again. The family's controlling the money and they're not paying. So they don't pay the nursing home. And at some point, the nursing home is going to send her back home or send her to a different facility, because as much as we'd like to think that we can cover the cost of long-term care, it's really, really expensive. And most people, the statistic sort of goes up and down. Between 70 and 80% of people who are in long-term care in nursing homes, so they're not there just for a couple of weeks for rehab, but they're there 6 weeks, months on end, whatever, they end up going on Medicaid. But even then, even when you go on Medicaid, you still have to pay your part. And so families don't realize that, and they think they can keep the resident's check and that the resident can just stay in the nursing home because between Medicare and Medicaid, it's all covered, but it isn't. It doesn't work that way. So yeah, that's usually how the exploitation how families take advantage of residents. Yeah. Dick, oh, sure. I see your hand again, Dick.
Yeah, I'm curious, what range of cost do you see for long-term care facilities in terms of dollars per day for patients? I'm told it runs anywhere from $200 to $350 a day in Florida. So what do you see?
I can't tell you how much it is per day, but I can tell you that it's per month, it's thousands of dollars. So it might be $6,000 or $8,000 a month. And so what happens is, if you go in on Medicare, Medicare pays the first 20 days. And then after that first 20 days, it's the individual's cost is 100 and some a day. Maybe it's 130, 150. We don't really get into all of that too much, except that what happens most of the time is, for a resident who ends up staying in the facility, then they eventually need to make an application for Medicaid. And so, Medicaid pays a certain amount. So after the 100 days, I think it's 100 days, you get a Medicare. If you even do it that long and you're paying the copay, the individual copay, at some point Medicare isn't in it anymore. People think Medicare pays for long-term care, but it doesn't. Mostly it doesn't. And so then it's Medicaid who pays for part of it, but they look at your income to determine, well, how much does Medicaid need to pay? So let's say it's $5,000 in the nursing home and you get $1,200 a month in income. Well, almost all that $1,200 a month, you have to pay to the nursing home. You get to keep a little, but not very much. And then Medicaid pays the rest. If you have $1,500 worth of income, you pay almost all of your $1,500, and Medicaid pays a little less for you, but still, a fair amount. So, but it's thousands of dollars. I have a friend in Illinois. Her husband had long-term care insurance, but the payment was $6,000 a month. It was a private facility. She wanted him in the private facility, and she could afford to pay. She paid another $6,000. It was $12,000 a month for him. He got excellent care, excellent care. And she wanted to do it, and they could afford it. But most long-term care residents can't afford that. Most long-term care facilities are not 100% private pay. A few are. I don't know if you're aware of these things. They are called continuing care retirement communities. And so, you pay a big fee up front, and you can live in independent living. And then, if you need assisted living, you can move to the assisted living part. And then if you need a nursing home, you can move to the nursing home part, but it's all private pay. We have a few of those in Georgia, but only a few, because most people can't do it. They just can't afford it.
Several of the churches in Florida have the type of home where you pay $250,000 to get into your apartment, and they take care of you for life pretty much.
Mm-hmm.
And for those of us who become insurance poor by paying for long-term care insurance policies, we always are wondering if we're going to get enough out of it to cover us. So.
Yeah, exactly. Well, I hope you don't mind me telling you this story. One of the alumni from Georgia State, where I went to school, called one day, and he said, "Oh, I'm in long-term care insurance, and I'd just like to talk to you about long-term care insurance." And I said, "Well, we won't qualify." He said, "Yeah, you and your husband, sure you will." He said, No, I'm pretty sure we won't qualify." He said, "Well, let me just ask you a few questions." I said, "Okay. Does your husband have heart disease?" "Yes." "Is he diabetic?" "Yes." "Is he a smoker?" "Yes." "Does he have cancer?" "Yes." "Okay, you're right. I can't sell you long-term care insurance." I knew, it wouldn't be affordable for us. Thankfully, Doug didn't have to go to long-term care. So we were fortunate in that way. Now for me, I'm not a smoker. I don't have heart disease. I don't have diabetes. I probably should get it, but it's probably not affordable. So I just have to hope I won't need it. Yeah. So other questions?
So our Social Security check plus Medicaid would let us stay in a long-term care facility, right? Like a nursing home.
For most people, what happens is, when you go to the nursing home, you'll apply for Medicaid, and yes, your Social Security check will go to the facility mostly.
Mm-hmm.
In every state, you get to keep a small personal needs allowance, but every state does that a little bit differently. And that pays for things like, people don't think about this, but when you go to the hospital, right, you wear a hospital gown, they provide you all your food. You're probably not there long enough that you need a haircut or that you're going to put on makeup or whatever. But, if you live in a long-term care facility, your clothes might wear out. You don't want to wear a hospital gown. You want to wear clothing because this is your home, so you might need new shoes or new pair of pants. Well, the facility doesn't provide those. You might need a haircut. The facility doesn't cut your hair. You have to pay for a haircut. They may have a beautician come and will cut it for you, but you have to pay. Or, I was testifying at our Georgia General Assembly about increasing our personal needs allowance. And I happened to mention that, lots of women like to wear lipstick. And there was a legislator who sort of piped up and he said, my mom, she needed lipstick every single day. She didn't feel like she was dressed unless she had lipstick. And it's expensive. It's like $10 the tube or something. So it's helpful to have him kind of chime in so that people would understand that, the personal needs allowance, if you want a coat, you got to pay for it out of your pocket. Or if you want to, you know, get some M&Ms from the convenience store across the street, you gotta pay for it. You know, or if you're a smoker, and there are people who still are smokers, you know, the facility won't provide cigarettes for you. You gotta buy them. So, you know, you have to have that personal needs allowance. But yes, for most people, just about all their income goes toward the nursing home, and then Medicaid pays the rest. That was a very long-winded answer, Nancy. I'm sorry.
Are you allowed to save up your, what is it, $60 a month or something you can keep for your personal care?
Yes, you can save it. Yeah, but I don't know what it is in North Carolina. In fact, the personal needs allowance is a little more in Georgia, but if you hit $2,000, you're gonna be out of, you won't qualify for Medicaid anymore. So
Right.
facilities often, especially for those residents who might not be able to really say what they want, if their personal needs allowance gets up close like that, they might look and see, well, gosh, Mary hasn't had a pair of new shoes in 2 years. We're going to just go ahead and buy her some new shoes, or we're going to buy her some new, a new sweater, you know, do some things to keep it from getting to the place where it would knock them off of Medicaid.
Right.
Yeah.
Anybody else have any questions?
So could I just tell one other anecdote? Recently, our governor, we've had a surplus. And so one thing our governor did was anyone who was receiving Medicaid benefits got an electronic benefits card, you know, like a little credit card with, I can't remember now, it was $300 on it, something like that, as a benefit, just as a benefit. And so it went to nursing home residents that were on Medicaid. And in most instances, the facility would help the resident activate the card and have it available so that they could use it, you know, to buy a lipstick or snacks or whatever, but it was on an electronic benefit card, except there was one chain, and they'd recently gotten in trouble with the surveyors, and it was big trouble because they're not a very good provider. But they had told our ombudsman representative that they, under no circumstances were they going to help residents with dementia activate those cards. They were just going to wholesale and send them back to the state. And our ombudsman representative said, wait a minute, you know, these residents can use, you know, they might want a lipstick, they might want a treat, they might want their own shampoo or whatever. You can't just send them back. Well, our corporate told us we had to do that. So she called me and told me about it. And I said, well, let's do a couple of things. First of all, call them back and say, other facilities in your area are assisting residents to do this. So what do you say? No. Okay. Well, the Americans with Disabilities Act says you have to help people. And so I think you'd be in violation of the Americans with Disabilities Act if you take this action. So you tell me, you talk to your corporate folks and you tell me whether they want me to make a referral, because I'm going to make a referral because I think you're, well, sure enough. Oh, okay. We will help all these residents with their electronic benefit cards. So, you know, sometimes it's the craziest things that our ombudsman representatives run into, but they're pretty good advocates. And so if you feel like volunteering again, or any of those of you who might not have volunteered, you might reach out if this sounds appealing to you and see if you can help folks in your local area.
By the way, 10 minutes ago, they shot down the spy balloon over South Carolina's beach.
Oh, wow. Good for them.
God, I know it. Anyway, I thank you so much, Melanie,
Hear
and
that?
for being
10 minutes
adaptable
ago,
to
they shot
us.
the balloon down over South Carolina.
Good.
And you know, this wonderful presentation, and I knew absolutely nothing about this program, and I didn't even know it was available. So anyway, I'm glad it's recorded now and everything worked out well. And I just can't say how much I appreciate this for us.
Good. Well, I'm glad. Please, you know, tell your friends and your acquaintances if they know anybody in a long-term care facility. I know that word is a really awkward word, ombudsman, but just let them know every state has got ombudsman representatives out there trying to help long-term care residents. So
Hmm.
Call us up. The worst thing that happens to me is when a family member calls and says, I wish I had known because here's what happened. And then I think, oh, darn, yeah, I wish they'd known too. So,
Mhm. Well, anyway, thank you so much.
well, you're welcome. You're
It's been
welcome. And,
wonderful.
yeah.
Thank
yeah,
you.
Yeah, have a
Thank
good rest
you.
of your day.
Thank you.
Okay, bye.
Bye. Anyway, do you guys have any programs you'd like me to present? I was thinking one on pain. Nancy, do you have any? You could, there you go, unmute. Okay.
More about this idea of I was going to research it a bit more and maybe you can find the person for it, but be like if a family member is taking care of somebody in the home, how they're able to get paid for it rather. I think the laws changed recently or they're fixing to something. So I was gonna research a bit more about that. You know, if somebody is quit their job so they can take care of their aging mother, there's, you know, what kind of assistance have they got or something. So I was going to research that a bit. I'll be in touch with you about it.
Okay.
We have a few people going through troubles right now. So I didn't know as an organization, should we I'll just talk to you, Pat, about that. Help Carol and Bernetta right now. Two people that I think could use APPA's help right now. So
Okay,
I'll just leave that with Pat. I'll talk to you later.
okay,
Yeah, we were going to discuss that at our board meeting, which
That's
is,
2 weeks from now.
Yeah.
Yeah. Let's do that quicker.
oh, well, and next week I can't because I'm indisposed. So,
Well, some of us, well, Pat, Barb, Joe and I can talk. I don't know how long you Canadians want to stay on. You know, it's nice we had more people from out of state to begin with today.
you
Thanks.
see, since Wayne felt that he doesn't want to do flowers, we had thought that delivering a food.
Yeah.
And Carol was going to get back with me and, you know, relate. And so then, you know, I can call Pat or whatever, whenever she calls me back and says whatever she'd like, because she's pretty much going to be by herself. And I was thinking that maybe some of us, you know, could visit her and stuff too at times.